Good afternoon. Welcome, everybody, to another edition of Scoliosis World. I'm Dr. Mark Morningstar, your host, and I'm happy to say that Scoliosis World is sponsored chiefly by BackGenius. So, thank you to BackGenius for sponsorship. I want to dive right in today. I wasn't actually sure what I wanted to do for a topic until, honestly, I woke up this morning. Um, and I wanted to do the topic of bracing. And I think in all of the Scoliosis World podcast episodes I've ever done, I don't think I've actually tackled my thoughts on rigid bracing. So we're going to go ahead and talk about that today. And I'm going to talk about it from a perspective of my own opinions on bracing. And I think not necessarily whether it works as a tool or not, although I am going to cover some of the evidence. But I think in the larger scheme of how do we employ it and how do we implement it in terms of a child's management strategy or in an adult's management strategy in some cases. But I think first and foremost, what we have to understand is I, at least so you understand the perspective that I'm coming from with scoliosis management is that it's to me it's much the same way as a builder building a house. If all I ever used was a hammer, I'm probably not going to get a house, or at least a very good one, or it's going to take forever. I need a lot of tools in my arsenal to build a house. To me, scoliosis is such a comprehensive, multi system, multifactorial problem that if you don't have and if you aren't employing several tools, you're probably not going to get the outcome that you want. So, to me, a rigid brace is no different than that hammer. I need a lot of tools, not just a hammer, in order to effectively work. Now, there are times where maybe I don't need a hammer. If I'm cutting a piece of wood or I'm trying to, screw together two pieces of, two by fours, well, maybe I don't actually need a hammer. So you have to know what tool is used for what job. And really to compare that, it's about knowing when you have a patient in front of you, depending on where they're at growth wise, depending on what their risk of curve progression is at that time, depending on their goals. In other words, patient selection is really going to be the key in determining if a rigid brace is appropriate for the patient in front of you. And so that's kind of the criteria I use. So to just have an argument to say bracing works, bracing doesn't work, etc., I think that's sort of a false flag. I think you have to look at it more in the perspective of a brace can be helpful, but it can also do absolutely nothing for you at the same time. So you have to know when to use it. So that's a little bit about what I that's how I kind of look at it, right? So for example, the classical criteria for using a brace are going to be in a child who is, for example, easily identifiable in a female who has not had her first menstrual period yet. So, in terms of bone maturity, she's at what we call a riser zero up to a riser two. That is kind of the standard criteria that the Scoliosis Research Society would say doing or starting a bracing treatment would be appropriate. So that's really the main age range. Now, there are certainly doctors out there, orthos, chiros, people, you know, physical medicine MDs and DOs that do bracing outside of that criteria as kind of an off-label use. But you better have very concrete evidence that it's actually going to do something for a person who's not in that criteria or not fulfilling those guidelines. So, but classically, that's the place to do it. And the reason being is because that's typically where a child still has a lot of growth remaining. And it's still where they're in the highest risk for somewhat or high rapid curve progression. When we talk about rapid curve progression, I mean, you can have a curve increase 5 to 7 degrees a month during a growth spurt. So to me, those times are very pragmatic to use a hard brace because you want to try to get hours and time against that ongoing progression. Now, you can debate about what's the most logical prescription as far as wear time for the brace and that sort of a thing. So, for example, there are proponents who will say you have to wear a brace 18 to 23 hours a day in order for it to be effective. But there are studies that show that kids who are just sleeping in certain braces get a very similar amount or achieve a very similar outcome compared to kids who wear it 18 to 23 hours a day. So that is a little bit debatable too. And I think just in terms of physiology, when a child is sleeping in a brace, now bear in mind that as a child grows, most of that growth is going to be done at nighttime while they're sleeping. Well, they're not, and it's not that they're not growing during the daytime, but the other downside of daytime bracing is that you're now going to incorporate a certain measure of muscle deconditioning into the fray because you're wearing a brace during the daytime, so your own torso musculature is not working as hard as it normally does. So it's daytime bracing is sort of a double-edged sword. Now, there are certainly times where it's necessary. And I can think as easy examples off the top of my head, kids who have a neuromuscular scoliosis where their torso muscular control is very discoordinated or very weak, or in kids who have hypermobility syndromes, Ehlers-Danlos or Marfan's, or other things where their natural ligament tendon tissue is much more elastic and stretchable compared to somebody else. So in those instances, sure, daytime bracing makes a lot of sense. And that's not to say that it doesn't make sense outside of those parameters, but I think you have to take it on an individual basis. You can't just automatically say, well, you're here in this criteria, so we're going to give you a brace. That doesn't fit every child. Not every house has the same toilet. Not every house has the same carpet. Not every house has carpet. Some have wood floors, right? So you have to take the individual person in front of you, knowing all of the data about that person at that moment in order to decide if certain tools are going to be used to work with that patient. Bracing is but one of those tools. So now, I myself in clinical practice, I use bracing quite frequently, but only rarely do I use it for daytime prescription. Now, that's not to say that I won't. Or if I do prescribe it during the daytime, it's usually in the evening hours when we're starting to undergo a lot of natural postural collapse because, let's face it, at some point during the day, gravity wins. And then when that happens, we undergo what we call postural collapse. And the torso starts collapsing, quite literally. It's just amplified when you have a curvature. So sometimes it makes sense to prescribe a brace for, say, the latter 3 to 4 hours at nighttime before bed and then sleep in it. And then at that point, you're still getting a good, potentially 12 to 14 hours of total wear time between nighttime and those latter 3, 4 hours, at night. So you're still getting a very good amount of wear time. So, and then in that regard, from a day-to-day logistics issue, you're not running into the fact that now the child doesn't have to wear it to school, because what child wants to wear a brace to school? That brace is now not probably interfering with that child's extracurricular activities. Maybe they're in dance or cheer, or they're in baseball or softball or competitive swimming, whatever the case may be. Now, wearing that brace is not going to interfere with those things. Because I think at the end of the day, the most important thing is that you have to let a kid be a kid. We only get to be a kid once. And I think the most important part of childhood is to actually get to experience all of the fun of childhood without saying, look, you got to wear a brace and now you can't participate in half the things that your mates can't or can because they don't have to wear a brace. So those are all things that a provider like myself has to bear in mind when we decide on whether or not to prescribe a hard brace, because it doesn't just exist in a vacuum. Now, I think it's easy for people to just say, okay, we're going to wear a brace 23 hours a day. Well, guess what? I'm not the one that has to go home and watch you put it on or try to get it on you, monitor your wear time. It's easy for me to just shout directions, right? It's another thing to say, are those directions practically followable? And if they're not, you can have the greatest treatment out there, but if nobody does it, then what is it worth? I mean, that's just the reality at the end of the day. So I want to touch a little bit on bracing constructs or types of bracing, because there's a lot of different types, and there are certainly studies that compare different types of bracing. And I mentioned in a general sense a full-time 18 to 23 hour kind of a brace. And then there are also braces that are intended to only be worn at nighttime while you're sleeping. I think one of the biggest ones that comes to mind is for sleeping, Providence nighttime brace. And as a Providence brace is a brace that I use very frequently for my patients. It's a little bit lower profile, so it's a little bit more comfortable for a child to sleep in. The enclosure and the straps are on the front, so again, it makes it easier to sleep on your back if that's what you prefer. And it's made in such a way that it's not as disruptive on the child, meaning they're not as likely to wake up in the middle of the night or to be uncomfortable in the nighttime to the point that they wake up and just kind of, in a half awake manner, when they're still sort of out of it, they just unstrap it and just kind of, go back to sleep. So the compliance tends to be very reasonable for a Providence brace. Unlike some of the more conventional braces, like a Boston brace or some of the ones where the enclosures are on the back, it's a very sort of a symmetrical or two-dimensional type of a brace. And I'm not picking on anyone in particular, but really the better braces in totality are the more three-dimensional kinds of bracing. Now, some of that is not necessarily just the brace, but it also has to do with the way in which that brace is made, meaning how are you fitting the patient? So you could cast the patient. You can just take superficial measurements, do a measurement of the width of their hips, width of their chest, depth of their torso and pelvis, that kind of thing, length of their torso. The problem is you're not really getting a custom brace that way. You're getting what they call an off the shelf brace, which means any child who fits those basic measurements could wear that brace. Well, the reality is there might be 1,000 other kids who could wear that brace if they have those same measurements. So then the argument becomes, is that brace really custom? Versus if I were to do a 360-degree computer scan or video scan of that child's torso, now we develop a computer model of their torso and we make a brace based on their individual torso. So that when that brace is done, that child and only that child can wear that brace because it's very specific to them. Now, to go a step further, and this is just bracing logic, let's say, but I think the way that you scan a patient and the way that you submit the computer model of the patient is very important in determining how good the brace is going to be. Everybody wants to blame the brace as if like people who are anti-bracing, for example, blame the brace itself. When in reality, it probably wasn't the brace per se. It was the way it was scanned or fitted to the patient in the first place, meaning the orthotist's skill. And in some cases, the provider, meaning the orthopedic surgeon who's ever prescribing it, their skill level with prescribing it. For example, if I have a child who has a predominant right torso shift, which would be typical in, say, a right thoracic scoliosis pattern, when I scan that child for a brace, the computer is going to make a torso of my current position, which is this. And I'm just exaggerating, right? Well, I don't want to make a brace based on the current positioning of the torso. What I would rather do is take the scan of that child's torso. And what's very nice about computer scans, and really why they're the most advantageous way to do it, is that you can then take that computer model and invert it. So you're basically essentially creating a mirror image of that patient's torso. So now, instead of the model looking like this, the model quite literally looks like this. And it's a mirror image or hyper corrected, however you want to phrase it. And this then becomes how the brace gets made. The advantage then, logically speaking, if obviously I'm going to put a child in a brace, I want to put them in a brace that holds the corrected or the desired position, not the current position. And really, when you break it down, I think that's why most places when a child gets a brace, The prescriber's office or the prescriber themselves will tell the patient, well, the goal of bracing is not to improve the curve, it's to only keep it where it's at and prevent it from worsening. Well, that makes sense if I'm putting a brace on in the current position. I'm trying to hold the current position and not let it get worse. But why not use a brace to try to correct? But the difference between whether you're going to try to keep the curve the same or try to improve the curve ultimately lies in, what is your reference point? Am I making a brace from the desired corrected position or the current one? To me, that makes all the difference in bracing outcomes. But the problem is not everybody does that. And there are only certain providers that do that. So you have to get a provider who is willing and able and knows how to tell the orthotist to do that mirror image. So, for example, in our office, we have an orthotist that works here with my patients every week. And in my patients who get scanned for a brace, automatically, he doesn't even ask me anymore. He knows that we are going to invert the model to create a hypercorrected torso model because that's what I want the brace to hold. Now, there's a little bit of a trade off with that in the sense that because it is so corrective in that sense, sometimes it can be tough for some kids to get used to. If all of a sudden I were to go get braces put on my teeth and I put on like the most stretch or strain or I put the wires in such a way where I create a lot of force, my teeth are going to hurt really bad and I'm really not going to want to wear braces. The difference is with braces on your teeth, you can't take them off. They're cemented on your teeth. Whereas a child, if they get uncomfortable in their scoliosis brace, they just, and I pull my brace off. So you at least still have to make that brace in such a way that not only is it corrective or has the potential to be corrective, but it also has to be wearable, on a day-to-day basis. And as a provider, it's always striking that balance between the two, but it can be done and we do it on a regular basis. But again, I think ultimately at the end of the day, you want to have a brace that is a three-dimensional version of a brace, not a two-dimensional, because scoliosis is a three-dimensional deformity. Everybody knows that. Everybody preaches that. But yet, there are still types of braces that exist that basically only work in two dimensions. Or worse yet, they're basically just like a hard corset, and all they do is squeeze from every direction. And at that point, they're really not corrective. And they're even worse at just trying to keep the curve where it's at. So now there are all kinds of potential reasons for that. And I'm not going to disparage anybody on my podcast, certainly, but I think in some cases, there are financial motivations to ensure that a brace doesn't work, but I digress. I obviously want a brace to work because obviously I'm a non-surgical provider. So my hope is that I can spare people from needing to undergo scoliosis surgery. And that's the ultimate goal for me. And at the same time, not only just spare the surgery, but also improve the curve and make it better than what it was when we started. And so I kind of pride myself on being able to do that. So literature. So just to kind of give you a little bit of literature background on bracing here. We have various studies here that bracing in a couple of ways. I would say just as kind of easy background info, probably one of the largest bracing studies ever done was called the Braced Study. And it was published back in, I believe it was 2007, somewhere in there. It was a while ago. And they've done multiple derivative studies from that data. This is one of those derivative studies. This one was published here just in the journal Spine just last year, where they were using the Braced Study criteria and data to predict which children would get a good result from bracing versus children who wouldn't. Very interesting study. And what they found, and I'll just kind of read you the easy conclusion here, that the criteria that they created in here, meaning predicting whether or not somebody would progress to surgery, whether or not a child had a good outcome, and what kind of children would likely have a bad outcome, even if they were fully compliant with bracing. And And the whole goal of this, as they conclude, is that they want to decrease the use of overbracing. And this is one of the first studies to actually suggest that there are kids out there who have curves who are prescribed a brace who don't need a brace because either they don't fit the criteria, or based on their metrics and their growth, stages, they're not good candidates. And it's likely that they won't get a good response. Because if there's one, again, going back to what I said before about you only get to be a child once. Well, if a child is likely to not respond well to a hard brace, why prescribe one? And why make that child suffer through that treatment when they were probably not going to get a good response anyway? So again, going back all the way back to the analogy of when I build a house, building a house is like patient selection. And I have to use my tools based on the individual projects that I have going on at a time. Patient care, patient management is about selecting for that person in front of you what treatments are the most appropriate at that moment. And then that's what we're going to do. Systematic review. So we have a bunch of, in fact, I believe all of the studies here that I wanted to touch on are systematic reviews or clinical trials. So for example, this one is a clinical trial. This is back from 2013. Again, this is the braced study as I was talking about. Effects of bracing in adolescents with idiopathic scoliosis. This is from the New England Journal of Medicine. So again, probably one of the most prestigious medical journals there is. Bracing significantly decreased the progression of high-risk curves to the surgery threshold for patients with scoliosis. The benefit increased with longer hours of brace wear. And what they found is that the rate of treatment success was 72% with bracing compared to 48% in kids who did nothing, meaning they just watched them. There is a significant positive association between the hours of brace wear and the rate of treatment success. Now, this is the original brace study. So, but if you extrapolate that out further and you actually get into the meat of the data, what you find is that you sort of have, they talk about the longer you wear it, the better. Well, that tended to be true as long as you were at 15 hours or more, you were going to get a far better benefit than if you wore it less than 15 hours. But when you get into the weeds a little bit further on that, there really isn't a difference between wearing it 15 hours and wearing it 23 hours, according to this study. So if I'm a family making the decision to brace and my child's expected to wear a brace, if my outcome really isn't any different at 15 hours of brace wear versus 23 hours of brace wear, why in the world would I ever wear it 23 if I could just wear it 15 and get basically the same result? Now, also bear in mind that this is bracing by itself. Again, when we talk about management, like here in our office, we are not doing just bracing. In fact, I don't know if I've ever had a patient only do bracing. We are always adding other components in with it. Now, those might not be physical treatment components, because again, as anybody who pays attention to my podcast knows, there's a whole host of metabolic and genetic, hormonal, etc., all kinds of other treatment strategies that we employ that aren't necessarily physical treatments in that sense. But we're always doing something with it in the hopes that we are treating the condition from as comprehensive of a mindset as possible. So that was the bracing study. And then this is another one, Open Orthopedic Journal, 2017. Again, this is a systematic review. Now, what they found, braces with high in-brace correction should be used in conjunction with physical scoliosis specific exercises, or physiotherapeutic scoliosis specific exercises, meaning scoliosis specific therapy. Now, they don't recommend any specific type of scoliosis specific exercises. All they're saying is when we talk about non-surgical treatment, the best responses when we look at all of the research studies ever published, and this is they looked at all papers between 2001 and 2017. So in the prior 16 years, what they found is that the results were always the best when people did both bracing and exercises, and when the braces showed a high level of in-brace correction. Meaning, and they didn't talk about this in the brace study, but this is a very big key criteria, and it's something that we always shoot for here in the office as well, is that the when you are evaluating a brace. So, for example, let's say Sally comes in today and gets a brace. Once we have everything fitted to her, we are going to take an in-brace x-ray to compare to her regular x-ray. When I compare the two, at a minimum, I want to make sure that that brace improves her curve by at least half. If it doesn't, it's not good enough. Reason being is because there are other studies, and I didn't bring those out here, but there are individual studies that show that if you don't achieve half or better in-brace correction, that along with wear time are the two most important criteria, essentially 1 and 1A, as far as getting a good bracing outcome by the time the child's done growing. So we have always followed that component or that factor. So if that child's brace isn't providing that 50% improvement, then we are right then and there fixing and modifying that brace in order to get it to 50%. And then we will repeat the in-brace x-ray until we are satisfied that that brace is providing enough in-brace correction. And then, of course, everybody who knows me knows we do a lot of boot camp therapy and other stuff here in concert with the brace. They're never getting just the brace. So we are handling that child and managing that child from a wide variety of perspectives in order to get the best outcome possible. And that's Open Orthopedic Journal, 2017. So that was, again, systematic review. So systematic reviews are the single most powerful study design there is. So generally speaking, whatever conclusions they make, you can pretty much gauge your practice and make clinical recommendations based on the conclusions of those kinds of studies. This is another one here, comparison between Boston brace and European braces. And this is something that I've been saying for a long time, although this study was done in 2023, published at the end of 2023. They looked at all studies between 1976 and January of 2023. And what they did is to say, okay, we're going to divide these up into, let's say, American bracing, which really Boston brace has been kind of the standard now for 50 odd years, and European bracing, which are more the three-dimensional kinds of bracing, or some people will call it Chenot style bracing, after a French orthotist. And what they found, they literally went through 176 studies, and what they concluded was that both braces tended to be effective if they were compliant with the wear schedule. But none of the patients treated with a Boston brace achieved curve correction, meaning by definition, improved their curves 6 degrees or more by the time they were done growing. And let's see. Curve correction was achieved in half of the patients treated with a Chenot brace or a European brace. So again, none got a correction with a Boston. Almost half, 49%, got a correction with European bracing. Treatment failure, most notably also, for American bracing was about 28%, meaning treatment failure by their definitions were that the child ended up needing to go on to have surgery. That was for a Boston brace, 28%. With the European braces, it was 15%. So again, even based off of all of this, and we're talking about 50 years of data, A Boston brace fails twice as much as a European three-dimensional brace or Chinot brace. And you have almost a 50-50 chance of getting some measure of curve improvement with a Chinot European style brace versus effectively a 0% chance with a Boston brace. I think that's pretty telling myself. So we don't typically recommend Boston braces hardly ever. Now, there are times, and I'll say this and some of this again, it depends on the orthotist, depends on the person making and ordering the brace, depends on how you prescribe it. There are times, and we see this a lot in young kids. I mean, like 6, 7, 8 years old, where they're very little, very thin, no body fat. Well, sometimes when you make a Chinot brace for those patients, because there's no padding on the inside of it, it can be very tough for them to get used to. So, very frequently, what we'll do in our office when we do a brace for a child that young is to do a Boston brace, but you can have it built like a three-dimensional version of a European Chinot brace. It just has more padding on the inside of it. So it's still technically a Boston, or now what some places call a Boston 3D, because they're catching up with this data at the same time. And now that brace becomes much more comfortable for that child to wear, but at the same time, now you're still getting the better benefit as compared to just a classical Boston brace. So again, this is the data, right? And this isn't my opinion. These studies are here readily available, and they're new studies. This isn't a study from 1985. This is a study published, within the last 2 years, and it's a study evaluating all of the bracing data published over the last 50 years, almost 50 years, 49 years. So, a very, very good study there. And to me, it just reinforces the fact that the way I'm practicing and the way I feel like BackGenius providers are practicing in general is that they are practicing with the most up-to-date standards, using the most up-to-date literature, with the idea that you have to treat the whole patient. We know scoliosis is a multifactorial problem. And if you're not good about addressing hormone issues, addressing genetic predisposition, addressing risk of curve progression through neurotransmitter problems and genetic risk, you're not really, your treatment's going to be doomed to fail. And the bracing, while it doesn't really offer a whole lot when you use it by itself per se, it does have a very good chance to help when you combine it with an exercise-based therapy of some type. And there are many good types out there. So if you live in a part of the United States or world where you don't have access to somebody like me, well, there are a number of good physical therapy treatments out there that are scoliosis specific. There's, ScoliSmart, there's Clear Institute, there's Schroth Therapy, there's Scoli Care, Scoli Balance. There are a number of very good therapies here in the States that you can get. And they all can claim success to certain degrees. Just like there are various kinds of bracing. You have the Chinot style bracing that works very well. You have a spine core brace. So there are a number of ways that you can work with for each child in front of you. The trick is don't use any one of them for everybody. Because again, now you're running into this, when all you have is a hammer, everything looks like a nail mentality. You're better off learning a variety of physical treatment means and applying which of those physical means is going to be best for the patient in front of you. And when you out in viewer land are looking for a provider to work with your child or yourself perhaps, my suggestion is that you look for a provider who is willing to take you as you are and say, okay, based on where you're at, these are all of the things that we can throw into the mix to best help you presently. And the next person's treatment is going to look a little bit different. And it should, because you're two different people. So bracing can be very, very productive. It can also be entirely useless. It just depends on how you use it. Again, back to my hammer. A hammer works wonderfully if I'm pounding a nail into a piece of wood. But if I use that same hammer and I try to pound a screw into a 2x4, it's not going to work as well. I might be able to get the job done, but it's going to require a lot more effort for sure. And I might end up messing up the wood. So again, the right tool for the right time at the right stage of development always produces the best outcome. So that's all I have for this week. Again, I would like to thank BackGenius for sponsoring our Scoliosis World podcast. Please, 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 if you like the podcast, please subscribe on the channel, on the YouTube channel here, so that we can grow our viewership. And we'll be seeing you over the course of the spring and summer. Have a great day, everybody.